Welcome to today's webinar, run jointly between the Pan-African Thoracic Society and the European Respiratory Society. This is the second in the series after the successful session on bronchiectasis in January earlier this year. So today's focus will be on community-acquired pneumonia with two excellent speakers awaiting us, Professor Ameena Goga in South Africa and Dr. Massimiliano in Italy. We'll look at the prevalence and the diagnostics and prevention and treatment strategies in high and low income settings. So first we will hear both talks, and then there will be about 10 to 15 minutes of question and answers. So please post any questions during the talks, and Dr. Anne Irungu in Kenya and myself, Stefan Unger in Scotland in the UK, will try and direct at least some of your questions to the speakers. So all questions that cannot be answered in the time given will be forwarded to the speakers and will be posted online. So let me introduce our first speaker. So Dr. Massimiliano, he works as a pediatrician in Udine in Italy after a stint in Zimbabwe and a fellowship at the Erasmus University in Rotterdam in the Netherlands, where he focused on nasal nitric oxide use in pediatrics. He undertook his PhD with the Faculty of Medicine in Tampere in Finland under the supervision of Professor Martti Korpi. He undertook a serological study on the etiology of pediatric community-acquired pneumonia with specific focus on newly identified agents. So stemming from that, he has published several papers on the topic of community-acquired pneumonia, and we are really looking forward to his overview of the topic. So thank you, Dr. Don, for speaking to us today. It's over to you now. If you can share your screen, please. Thank you.
Hello to you all. Many thanks to the European Respiratory Society and the Pan-African Thoracic Society for the invitation to this nice webinar. And many thanks to Dr. Stefan Unger from Scotland, and in particular to Professor Marielle Peenburg. I'm going to speak about community-acquired pneumonia in the high-income countries, touching 11 points and doing a general consideration of this common pediatric infectious disease. Community-acquired pneumonia is a disease clinically characterized by the presence of signs and symptoms of pneumonia due to an infection acquired outside the hospital. In high-income countries, the definition of pneumonia is achieved generally, but not always, by means chest X-ray. Otherwise, in low-income countries, the definition is more practical. In fact, it is usually used the term low respiratory tract infection for the difficulty to obtain radiological images. The incidence of pneumonia decreases when children grow up. In fact, you can look that the incidence in the preschool children group is higher than in the school children and in the adolescent age group. The overall incidence in the European and American populations is that up to 15 cases per 1,000 per year. The overall hospitalization rate range from 1 to 4 per 1,000 per year, and is a bit higher in the small children and a bit lower in the older ones. Mortality rate in the high income countries is 10 times smaller than in low income countries. Risk factors for pediatric community acquired pneumonia are low socio-economical levels, exposition to cigarette smoking, and in general, important comorbidities. The determination of the etiology of pediatric CAP in the pediatric age is difficult for several laboratory and microbiological reasons that you can look in this slide. For example, the paucity of positive findings in blood or pleural cultures, the low specificity of some antigen tests, the dependence of antibody response on age, the difficulty to obtain from children biological samples from the upper respiratory tract, and the scarce utility of culture from the upper respiratory tract for the presence of normal flora, and the difficulty to obtain biological samples from lower respiratory tract only that are useful and above all indicated only for severe cases. The etiological findings in pediatric pneumonia studies derive also from four important matters that are the study design, in the sense that the etiology will be different in case of inclusion of inpatients or outpatients. Also for the occurrence of specific epidemics, or for example, for the inclusion and exclusion criteria. Other variables, other study variables are the age distribution, the severity of disease, and the quantity of tests that the authors decided to use for their studies. A high number of infective agents may cause pneumonia in childhood. As you can see in this slide, I decided to split them into columns. On the left side of the slide, you can see the common agents, viruses, typical and atypical bacteria, and on the right there is a description, a table with the uncommon agents. A significant number of pneumonia, I mean from 8 to about 40%, are mixed infections, in which many of these pathogens may be involved. Viral pediatric pneumonia are common not only in low income but also in high income countries. The most common agent is respiratory syncytial virus that accounts for about 30% of viral etiology, and in general respiratory viruses account for up to 35% of all pediatric pneumonia cases, and up to almost 70% of hospitalizations. And above all, respiratory viruses are more frequently found in preschool children. Streptococcus pneumoniae, also named Pneumococcus, is the most commonly detected bacterium in pediatric pneumonia across all ages, followed by Mycoplasma pneumoniae, Chlamydia pneumoniae, Haemophilus influenzae, and others. We have to take in mind the possibility to have or to find bacterial co-infections, in the other sense, typical and atypical bacteria, above all when we decide to start an antibiotic course in, above all, older children with pneumonia. A useful classification in a clinical setting is based on age, which correctly predicts the likely etiology of pneumonia in children. Look at the green, for example, the green line. Streptococcus pneumoniae remains the single most common bacterial cause across all ages. And CAP cases in the first 3 weeks of age are rare and associated with perinatal infections. Between 3 weeks and 3 months, the cases are rare too, and are due frequently by chlamydia, trachomatis, and bordetella pertussis. I didn't sign the line of viral infection, but I repeat that viral infection, above all respiratory syncytial virus, are more frequently found in children from 4 months to 4 years of age. Finally, look at the red line that represents atypical pathogens, and you can imagine that Mycoplasma and Chlamydia pneumonia are more typical in school children from 6 to 10 years and adolescents, being detectable also in children aged less than 5 years. Clinical symptoms may help more than clinical signs in the final diagnosis. Clinical symptoms are, above all, fever, high respiratory rate, dyspnea, cough, chest or abdominal pain, vomiting, headache, and they vary with age and are absolutely not specific for an etiological diagnosis. Tachypnea, as only clinical sign, has the highest sensitivity and specificity for, above all, for radiologically defined pediatric CAP. There is a large overlapping of clinical findings in the various types of pneumonia, but in the everyday practice, it is perhaps possible to understand if a child may suffer from a bacterial rather than a viral pneumonia, in the sense that if we are in front of a child of any age that appears not bad, or practically appears as a toxic appearance, with high fever, with tachypnea, with signs of respiratory distress and consolidation signs on chest X-ray, maybe that child is suffering from a bacterial pneumonia. On the other hand, if a little child is a child with wheezing, with low fever, without tachypnea, but with chest wall recessions and various signs, radiological signs that may be hyperinflation or the possibility or atelectasis, it may suffer from viral CAP. Chest X-ray is the benchmark, is the gold standard, I can say, the gold standard of the radiological investigation, even if all the international guidelines not consider in as a routine investigation, but it has to be used only in severe cases, or when we hypothesize a complication. At the same, lateral views should not be performed routinely. So follow up chest X-ray is indicated, is useful for the cases of round pneumonia, atelectasis, or persisting symptoms. In the end, chest X-ray is not able to differentiate the etiology of pediatric pneumonia. This is only an example of the appearance in a chest X-ray of a pneumococcal pneumonia. Practically, there is a consolidation or alveolar infiltration in the superior segment of the right lower lobe. Effectively, it is difficult to understand where the few air bronchograms are present. Another tool, important radiological tool in the investigation of pediatric pneumonia is lung ultrasound, even if presently it is not considered in the international guidelines from Europe and the USA, but only for the identification and the utility in the management of pleural effusions. Anyway, the recent tendency is to consider lung ultrasound also in the diagnostic evaluation of pediatric alveolar infiltrations as an important complementary tool nearby chest X-ray. There are positive and negative characteristics of this tool, and they are that is simple, is a rapid, repeatable, and non-invasive tool. It may be done near to the patient. It allows to spare ionizing radiation and permits to do a simple follow-up. On contrary, the bone blocks the ultrasound beam. It is not able to identify subpleural consolidations. It is difficult to reach particular lung areas. It is experience dependence, and it not allows a panoramic vision as chest X-ray does. These are only few examples of how a normal lung pattern is in this image. The pleural line in the movie is has the appearance of the pleural gliding, and normal findings are the A lines that are parallel to the pleural line. Pathological findings are firstly in rapid succession are multiple confluent B lines in a picture of in a clinical or ultrasound picture of interstitial alveolar pattern that may represent the first stages of a pneumonia. This is a second stage of pneumonia with the identification of a lung consolidation in which we can see arborescent air bronchograms, and this is a case of pleural effusion. General investigation remain history and physical examination also in 2021 because they are useful to determine comorbidities and to assess severity, pulse oximetry, and the acute phase reactance white blood cell counts, erythrocyte sedimentation rate, PCR, protein C, C protein, and procalcitonin. But these reactants are not useful to distinguish the etiology of pediatric CAP. They are not indicated in simple pediatric cases, but they are useful to guide and to manage challenging cases. Microbiological investigations are not to consider as a routine investigation in the community, but they are obviously very useful in the hospital settings, above all for severe and complicated cases. For bacterial CAP, they are blood culture, pleural fluid examination, serology, the detection of urinary pneumococcal antigen, and the real-time PCR. For atypical and viral CAP, important are serology and real-time PCR, along with viral culture and antigen detection. This is a slide in which you can see the differences between mild and severe cases, and you can see that the clinical presentations are different considering the age of our patients. Anyway, the severity assessment is important to understand if a child is manageable in the community or in the hospital. Risk factors for hospital admissions are comorbidities, history of severe or recurrent pneumonia, and parental anxiety. Basic medical reassessment is mandatory in case of swinging on or persistent fever after above all after 48 hours after starting treatment, in case of dyspnea, or in other terms, effort of breathing, or in case of agitated and distressed children. In hospital settings, is important also to identify vital signs. Two are the clinical scenarios for the transfer of a child in or to the pediatric intensive care unit. And these scenarios are the severe respiratory failure requiring assisted ventilation, and pneumonia cases complicated by septicemia. Key features are the failure to maintain a normal oxygen saturation in oxygen therapy, shock signs, increased respiratory and heart rate with clinical evidence of severe respiratory distress and exhaustion, and recurrent apnea or slow irregular breathing. The general management in the community includes the management of fever, the identification of possible signs of dehydration, deterioration, or signs of complication, and a safety net, the organization of a safety net for parents or other caregivers. The same aspects are valid for the hospital setting, along with the oxygen therapy when needed, and the fluid therapy, along with obviously daily electrolyte monitoring in case of dyspnea, vomit, or severe illness conditions. What about the antibiotic? All children with a clear diagnosis of CAP should receive an antibiotic course, even if it could be a potential exception, that is the case of a pediatric pneumonia in a fully vaccinated child, young child with mild symptoms. Anyway, in the general practice, all children should receive an antibiotic course. Amoxicillin is recommended as first choice for oral antibiotic therapy in all children because it is effective against the majority of pathogens which can cause pneumonia, and because it is well tolerated and cheap. Co-amoxiclav may be useful in pneumonia due to mixed infection by influenza virus and Staphylococcus aureus, and macrolide can be used in case of penicillin allergy or in case of no response to the first line therapy, or when we suspect atypical pneumonia, or in case also of severe disease. Oral antibiotics are safe and effective also in severe pneumonia. Parenteral antibiotics may be prescribed in case of emesis or in case of severe pneumonia, in case of septicemia or complicated pneumonia, and ampicillin, co-amoxiclav, or third generation cephalosporins may be used for an intravenous course in case of severe pneumonia. Switch from parenteral to oral administration may happen only when there is a clear evidence of clinical improvement. A real optimal duration range from 3 to 7 days, depending on the literature. These are my last slides touching the problem of the complication of pneumonia, the most common of which is represented by emphysema, pleuric emphysema, for which the age more than 3 years and a recent varicella infection could be the risk factors. Symptoms of this kind of complications are persistent fever, more than 7 days, fever then not settle after the starting of the antibiotic therapy, chest pain, and or severe symptoms. Signs may be a reduction of chest expansion, dullness on percussion, reduction or absence breath sounds, and cyanosis. Investigations range from a classical blood workup to microbiological examinations, passing through the radiological investigation from chest X-ray to, as we saw a few minutes ago, lung ultrasound, and the use of the possible use of chest CT. The management involves the tertiary center, which is skilled for the fibrinolytic therapy or other more important therapies in the surgical field, and obviously high dose of parenteral antibiotics and the further long time of oral antibiotics. The prognosis is almost always very good. This is a simple case of right-sided large pleural effusion in a chest X-ray. A more rare complication is represented by necrotizing pneumonia. That is due generally by Staphylococcus aureus and Pneumococcus. Congenital lung abnormalities, bronchiectasis, immunodeficiency, or neurological disorders are its risk factors. Symptoms start insidiously and are represented above all persistent fever, not well appearance, night sweats. Signs are weight loss, chest pain, and productive sputum. Investigation are representing as usually by a blood workup, microbiology, and above all images that are from chest X-ray and chest CT. The management also for this complication is the transfer to a tertiary center, also for the surgical skills, and for the starting of high dose of parenteral antibiotics and following prolonged oral antibiotic course. This is a case of necrotizing pneumonia in a toddler, and on the left you can see the cavitary lesion in this chest X-ray image in the left upper lobe. And on the other side, in the right side, you can see the evidence of this complication in an actual chest CT scan. Other complications are septicemia and metastatic infections in various districts, hemolytic uremic syndrome, and bronchiectasis. Finally, vaccination had a major impact on pneumonia and child morbidity worldwide. I touch only two vaccination that are the important pneumococcal conjugate vaccine and the Haemophilus influenzae type B conjugate vaccine. The first one include the 13, the PCV 13 that offer a wider coverage and a more effective prevention than PCV7 against pneumococcal carriage and mucosal and invasive pneumococcal diseases. And the Haemophilus influenzae type B vaccine had, as you can see, an important positive effects on all kinds, all types of pediatric pneumonia. Thank you for the attention.
Thank you, Max, for that very comprehensive talk. Quite a number of questions in the chat box that we'll do after the next talk.
Okay.
Our next speaker, my name is Dr. Irungu. I'm in Kenya, Nairobi, Kenya. I'm a pediatrician and a chest specialist. Our next speaker is Professor Ameena Goga from Pretoria, South Africa. And she's a pediatrician, a pulmonologist, and an epidemiologist, the unit director at HIV Prevention Research Unit at the South Africa Medical Research Council. And she's going to be tackling the topic on reducing the burden of community-acquired pneumonia in children and which interventions work. Welcome, Ameena.
Thank you very much. Good evening, everyone, and thank you for the invitation. I hope that you can hear me. And is my sound okay? And can you see the slides?
Yes.
Okay, great. Thanks so much. So I'm going to be talking about reducing the burden of community-acquired pneumonia in children. And I'm going to focus specifically on what interventions work. So Massimiliano has spoken about community-acquired pneumonia, and I'm going to expand on what he said. So for my presentation today, I'm going to briefly talk about the context, Then I'm going to focus on interventions for the prevention of pneumonia, and I'll focus on primary prevention, which is preventing illness in the first place. Secondly, prevention, which is making sure that diagnosis happens timeously, and tertiary prevention, which means that once somebody has a disease, let us prevent complications. And I'm going to refer a little bit to 3 levels of care: community or public health level, primary health care level, and then hospital level. Then I'll summarize and end with a framework to reduce the burden of community-acquired pneumonia in children. I want to make the point that in what I talk about today, I'll suggest that we take a life course approach, and I'll explain to you why. And that's why we have the picture on the right-hand side of this diagram, of the slide. So firstly, let's talk about mortality from community-acquired pneumonia. And in 2008, we knew that pneumonia contributed to about 18% of childhood deaths in children under the age of 5. And that's what you see on your left-hand side. And on the right-hand side, I've got some 2017 figures. And here you see that despite the gap between 2008 and 2017, it still accounts for 15% of under 5 deaths in 2017, and it killed approximately 800,000 children worldwide. So remember also that pneumonia is not only associated with mortality, but it can also be associated with lifelong morbidity. And the major sequelae of community-acquired pneumonia are restrictive lung disease, obstructive lung disease, and bronchiectasis. And this usually occurs in about 6% of children after ambulatory pneumonia and 14% of children after hospitalization. Then we also have minor sequelae, which still affect quality of life. And the first one is chronic bronchitis, asthma, and then abnormal lung function. So let's focus now, as I said to you, I want us to adopt a life cycle approach to preventing community-acquired pneumonia. And it's because we see that childhood pneumonia causes not just immediate complications, but it can cause long-term complications. And so what we really want is to start preventing pneumonia from birth and making sure that children grow up as healthy adults, and that we really then remove the burden of disease from pneumonia, not just in children, but in adults as well. So I'll then focus on, so what do we do to prevent the burden of pneumonia at 3 levels of care? And as I said before, I'm going to speak about primary, secondary, and tertiary prevention of pneumonia. The first thing I want to talk about is feeding. And this is really important. It's a very general intervention, so it's not specific for pneumonia. But if you look at the data show that just by breastfeeding, and in particular exclusive breastfeeding for 6 months, or continued breastfeeding from 6 to 23 months, or ensuring adequate complementary feeding from 6 months of age, can reduce either pneumonia incidence or pneumonia mortality. So this slide then explains that in greater detail. What you see on your left-hand side at the top is exclusive breastfeeding for 6 months, which has been associated with a 23% reduction in pneumonia incidence. And then compared with exclusive breastfeeding between 0 to 5 months, predominant breastfeeding increases the risk of pneumonia incidence by 1.8 times, and partial breastfeeding increases the risk of pneumonia mortality 2.5 times. If there's no breastfeeding between 6 and 23 months, the risk of all-cause mortality, which includes pneumonia, is increased approximately 4 times, so 3.7 times. And if we have adequate complementary feeding from 6 months, we have a 6% reduction in all child deaths, including pneumonia. The second thing I want to talk about is micronutrients. And here I'll just highlight 3 of them. Firstly, vitamin A supplementation, which is associated with a 23% reduction in all-cause mortality in children, including pneumonia mortality in that all-cause mortality. Vitamin D supplementation, there is some controversy about it, but what has been found is that in children who are vitamin D deficient, and who are at an increased risk for community-acquired pneumonia, which they usually are, supplementation with 400 international units of vitamin D daily does prevent the risks of community-acquired pneumonia. What about zinc? So 10 milligrams per kilogram, 10 milligrams of zinc, or 20 milligrams for infants and 20 milligrams for older children per day significantly reduces the risk of pneumonia, particularly in malnourished children. I'm still on primary prevention of pneumonia, and here I'm referring to other interventions. So these are general interventions such as hand hygiene, environmental decontamination, and isolation of infected people, which has become very important in the face of influenza, RSV, and of course, SARS-CoV-2. Reducing household air pollution and improved living conditions, which is a general intervention, is very protective. What has been found is that halving household air pollution, so it's fires in the house, or any form of gas pollution in the house. So halving household air pollution exposure through a chimney stove reduced severe pneumonia by 33%, and large exposure reductions may further reduce the risk. The other thing I want to highlight, and this is a general intervention, is that maternal care, particularly optimizing maternal health from pregnancy onwards, and ensuring adequate antenatal care for mothers, has been associated with a reduction in community-acquired pneumonia in their newborn infants. Now I want to talk about preventing pneumonia through immunization, and I think many of us are familiar with this. Dr. Massimiliano spoke about this as well. The first one that is very common in our setting is BCG vaccination, which prevents disseminated TB in young children. The average effectiveness is 50%. There is a range between 0 and 84%, but because of the complications that are associated with TB, this is a critical intervention in resource-limited settings. The second one is measles vaccination, which has been found to be 85% effective in preventing pneumonia before the age of 1 year. And the third immunization is Haemophilus influenza type B, which is associated with a 6% reduction in severe pneumonia, an 18% reduction in radiologically confirmed pneumonia, and a 7% reduction in mortality. And in another study was found to be associated with about a 23 to 35% reduction in radiological pneumonia. The other one that you've heard about just now is Pneumococcus conjugate vaccine, and this has been associated with a reduction in childhood pneumonia mortality, a reduction in radiologically confirmed pneumonia, and a reduction in severe pneumonia. The other immunizations that are available to us include influenza vaccine, but this is not always accessible and often expensive. So in many settings, it's recommended annually for children above the age of 6 months or equal to 6 months of age and above, who are at risk for severe influenza. And so this includes children who have congenital cardiac disease, chronic lung disease, immunosuppression, and neuromuscular disease. The other primary pneumonia prevention modalities are broader. So they're HIV prevention in children, which is associated with a 2% reduction in childhood deaths. Ensuring that every HIV-infected child is started on antiretrovirals as soon as possible. And here I'm talking about triple antiretroviral therapy as soon as possible after diagnosis, and that they remain on treatment. Cotrimoxazole prophylaxis for HIV-infected children is critical. It has been associated with quite a reduction in pneumonia. For TB prevention, INH, particularly if a child is a household TB contact. But if a child is HIV-infected or has underlying immunosuppression and has a positive tuberculin skin test, then INH is also recommended for approximately 6 months. RSV prevention, RSV contributes to quite a burden of disease in younger children, but palivizumab is quite expensive, and we have limited stock in some of our resource-limited settings. So it's only recommended in ex-prems under the age of 6 months old, or children with congenital cardiac disease or chronic lung disease under the age of 1 year. given monthly only during the RSV season. So now I want to talk about secondary prevention of pneumonia. So what I spoke about already was how do we prevent, how do we protect children, and how do we prevent children from getting pneumonia. But once you have a child who's sick, a child who seeks care, how do we do secondary prevention of pneumonia as best as possible? And the first thing I want to say is we must know our counts. So what counts are we looking at? And this is not, these standards are set in stone. And they're a guideline, particularly for primary healthcare level. So know your counts, know the cutoffs for children under the age of 2 months, 2 months to 12 months, and then 12 months to 5 years. Know how to count. Quite a few, whether it's students, whether it's nurses, whether it's doctors, need to learn how to count. And thirdly, look at the child, okay? Training, mentoring, and supervision is extremely important so that we make sure that we measure respiratory rate as accurately as possible. But there are some challenges associated with just measuring respiratory rate because many conditions can cause tachypnea in children. So there may be an overdiagnosis of pneumonia if we simply rely on the tachypnea. And here I've just listed some of the other causes of tachypnea, including metabolic acidosis, fever, anxiety. So be sure that when you are counting, if you know how to count and you are counting, make sure you know that there are no other causes of tachypnea in this child. And remember that a respiratory rate then greater than 40 breaths per minute is not always strongly associated with a pneumonia diagnosis because one has got to take into account the other causes of tachypnea. What about pulse oximetry? And here, several studies have showed that pulse oximetry is better than respiratory rate. So the area under the receiver operating curve is not too bad, around 0.68, although in some instances it hasn't been significantly different. A big study in Malawi that enrolled approximately 3,600 children found that oximetry increased the referral rate for severely hypoxemic children who didn't have chest indrawing or danger signs, so it managed to identify them quicker. It increased the number of children who were correctly treated. It reduced the incorrect treatment of children with antibiotics. And when the researchers retrospectively applied the WHO guidelines, they failed to identify severely hypoxemic children by only applying the WHO guidelines, but these children were identified on oximetry. So that's quite important. What about chest X-ray? And this is now for secondary prevention. Chest X-ray is not always indicated, particularly if the child has an ambulatory pneumonia and is relatively well, but is indicated if the child is hospitalized or severely hypoxemic or has respiratory distress or has failed initial antibiotic therapy, or if you suspect another disease or complication like an empyema. But there are some challenges with chest X-ray. There are wide inter and intra-observer variability. There are differing radiological manifestations, and there is possible lack of sensitivity and specificity. What about ultrasound? And you heard a little bit about ultrasound just now. So it is possible for ultrasound to be used for secondary prevention, but the big thing about ultrasound is that it needs skilled users. Some people have been trained through courses of 1 hour up to 7 days, but the key thing here is that one needs supervision and mentorship post-training. The advantage of ultrasound is that it can be done at the bedside or while the child is in the caregiver's lap or while they're breastfeeding. So that is quite advantageous. What is the evidence for interventions to treat pneumonia? And here, health facility management for very severe pneumonia is critical. There's a 29 to 45% reduction in the case fatality rate if health facility management is correct, and correct use of antibiotics for the management of neonatal pneumonia reduced or caused neonatal mortality quite significantly. The other thing to mention is community-based case management of pneumonia, which doctors don't often like, but the truth is that in areas that have limited resources, where access to healthcare is not easy, community-based case management reduces pneumonia mortality by approximately 70%. What about zinc as part of treatment? So not as prevention. Here we're talking about treatment. It's associated with a 14 to 15% reduction in pneumonia incidence. And then I spoke about oxygen saturation monitoring and oxygen availability. So these are some of the interventions, as I've referred to until now, that can reduce the burden of community-acquired pneumonia. But what this slide shows is the coverage of these interventions. So the bars show the coverage and the red lines show the gaps in coverage. And what you'll notice is that some of the red lines are quite long because the coverage is only 39% for exclusive breastfeeding. And so there are huge gaps that we still need to fill, despite the fact that we're living in 2021. So this is one way of looking at the coverage gaps, and this is another way looking at coverage gaps. And you'll see here that even in this slide, promotion of breastfeeding coverage is low, so less than 40%, as you see there. Vitamin A supplementation, not too bad. We're close to 90%. And this comes from data from 75 countries. Then you have a whole package of interventions that improve living conditions, and you'll see coverage of some of these is very low. Look at water connection in the home, under 30%. Improved excreta disposal, which is just over 30%. So lots to be done there. Hib vaccine, not too bad, close to 90%. But antibiotics for pneumonia coverage is under 50%. And then we also notice that worldwide, there's inequity in coverage based on socioeconomic class. And what you see here in the dark green dot at the top is the richest in the population, and the gray is the poorest. And you'll see that for most interventions, there is a differential between rich and poor. There are several indicators to measure how we're doing to reduce the burden of disease, and these are 12 of these indicators. They are promoted by the World Health Organization. And analyses were done to identify that if 15 interventions are scaled up, and these are the 15 on the left-hand side, so improved water, hand washing with soap, improved sanitation, disposal of stools, breastfeeding promotion, then you see immunization, vitamin A, oral rehydration solution, zinc for diarrhea, antibiotics for dysentery, for pneumonia and case management. And you'll see that some of these are for diarrhea, but I'm presenting them because they were all lumped together as a package. So if these 15 interventions are scaled up at the historical pace, then by 2025, we will only reduce all deaths in under 5-year-olds by 26%, in neonates by 11%, will reduce pneumonia deaths by 51% and neonatal deaths by 35%. But if we increase coverage to 80% for all interventions and 90% or more for immunizations, then we're able to reduce all deaths by 34% and neonatal deaths by 12%. So, neonatal deaths needs more work, and pneumonia deaths by 67% for everyone, and 23% under the age of 5, and 44% for neonates. So that just gives you an idea of where we are if we had to implement all these interventions. In 2013, an expert panel used several criteria to rate interventions, and these criteria are on the left-hand side. They looked at deliverability, sustainability, the maximum effect, whether it would be acceptable to health workers as well as users, and how it would influence equity. And they came up with this list of interventions that need to be prioritized to reduce the burden of disease from pneumonia. Top on their list was pneumococcal vaccine, followed by the development of non-liquid and mucosal antibiotics, followed by improving uptake of existing vaccines, maternal immunization, improved oxygen systems, combination vaccinations. So, as we have combination vaccines, Pentaxim, vaccines in combinations, improving point of care diagnostics, indoor air pollution or sanitation, and then specific vaccines targeting neonatal bacterial pathogens. So that's what they came up with. There is a new pneumonia kit that the World Health Organization has put together. It's available to order. I think of note is that there are 2 modules to this kit. The first module contains oral and injectable antibiotics as recommended by the WHO treatment protocol for pneumonia with fast breathing or pneumonia with chest indrawing, so severe pneumonia. And the second module contains examination gloves and equipment such as a timer, a stethoscope, and a pulse oximeter. So these are currently available on the World Health Organization website. I'll quickly then summarize what I've said. When I looked at it, there actually is minimal recent data on reducing the burden of community-acquired pneumonia. If you look at all the references that I've cited, most of them are from kind of the 2008 to 2013, 2014. What we really need to do is scale up general interventions, breastfeeding, complementary feeding, water and sanitation access, scale up specific prophylaxis like immunization and micronutrients, strengthen early diagnosis and treatment, and then research different models of care and strategies to reduce the burden of community-acquired pneumonia. And so if one had to look at a framework at primary care level, secondary level, and tertiary level, at the bottom is where we need to do the most amount of work with the most number of interventions, including breastfeeding, immunization, improving standards of living, micronutrient supplementation, and community-based case management. In the middle, we need to make sure that health worker training is on track, that they're mentored and supervised to provide appropriate care. Pulse oximetry is a valuable tool, and let's do early referral for children who need care. And then at tertiary level, access to antibiotics, X-ray, the use of ultrasound, which can be extremely helpful, and then appropriate antibiotics. And thank you very much.
Thank you very much for an enlightening talk, Professor Goga. Loads of questions coming in from the audience, so please keep adding to the question box. Just to start off with our question and answer session now, just addressing you, Professor Goga, again. You talked quite a bit about supplementary feeding and micronutrients. What would be your recommendations for blanket or targeted macronutrient and or multiple micronutrient supplementation in children with moderate or at risk of malnutrition?
I think you asked two questions there. One is macronutrient supplementation and micronutrient. I think both are very important. In many settings in resource-limited countries, we have almost all children who are either macronutrient deficient or don't have enough access to macronutrients or micronutrient deficient. And so general access through food fortification, that's one way of doing it, or through food programs, so nutrition supplementation programs. I think the difficulty with these programs has always been how do you ensure continued access of these children to the program? And so, yes, they look good on paper, but putting them into practice is slightly more difficult.
Thank you very much. Maybe a question to Max. Dr. Don, are you there with your microphone and a camera? It was just, you mentioned necrotizing pneumonia, and in our experience using ultrasound to a certain diagnosis of necrosis has been poor, and we seem to undertake CT scans more frequently to direct further management. So do you think we should CT all children suspect of necrotizing pneumonia? And there's some question from the audience just saying, what fibrinolytics do we use, and when should we use VATS drainage in such complicated pneumonia cases?
Yes, I have only very few experience on necrotizing pneumonia, also because it is a very rare complication. It is possible, I think, to use ultrasound, lung ultrasound for the identification of this complication, but I think that the best intervention is for this kind of complication, the chest CT. And about what about the fibrinolytics? Yes, the use of fibrinolytics is the first we can tell surgical therapy in gross pleural empyema. The use of VATS video assisted thoracoscopy is indicated in case of failure of the fibrinolytic therapy. The most fibrinolytic therapy we use in my region is urokinases.
Thank you. Thank you. So maybe coming back to Professor Goga again, there was a nice question from Marielle. How do you explain the relative low decrease in deaths due to pneumonia in the under 5-year-olds compared to the older age with the 15 indicators you showed? I would expect greater decrease in the under 5s.
I think the under 5s are particularly vulnerable, and they are affected by not just the host mechanisms, but also affected by the environment. Whereas in the older children, they probably they've grown, their immune systems are grown, and so they are able to then respond to interventions in place. Whereas the under 5s are quite dependent on what is provided for them. And it's a combination of their own host responses plus environmental factors that contribute towards their disease, plus whatever other interventions are or are not provided by the health system. So many of the interventions to prevent pneumonia are provided in those very early critical times. And so I think it's because of that if we don't, so I think that was the question, right? Why are we not getting to the very young child? The other thing is that neonates, it's a completely different ballgame, and they're affected by different sets of circumstances. And that's why we always find that the getting the needle to move on neonatal mortality or incidence of pneumonia in neonates is often more difficult, because there you've got to consider a whole set of other factors that relate to mother as well as baby. So I hope I've answered the question.
Yeah, thank you. Back to Dr. John. What do you think is the future of lung ultrasound and pneumonia for the diagnosis and follow-up? And do you think that in the future, like kind of thoracic ultrasonography will replace a stethoscope? What do you think?
It's a nice question. I'm very curious to know if in the future next international guidelines, lung ultrasound will be considered as another tool along with chest X-ray in the diagnosis of pneumonia. In my experience, it is a very, very useful and simple tool to use point of care near the child, and it gives and gave me a great daily satisfaction. I don't think that the best thing to do is the substitution of the objective evaluation, because the objective evaluation, as I told during my presentation, along with the history, are, I think, the best tools to approach also in 2021 to a sick child. Anyway, I think that in the future, lung ultrasound, both in high-income and low-income countries, will be used more and more.
Thank you very much. Ameena, Anne, do you have any questions?
Question is directed to Max, and the question was from Jose, and he asks, why is it so difficult to get a biomarker that can differentiate viral from bacterial pneumonia? So that's one aspect of the same question. Marielle asks, are there clinical predictive tools that can be used, therefore, to differentiate bacterial and viral pneumonia to prevent overuse of antibiotics?
Yes, two nice questions too. About the first one, we know that because there is a literature evidence that the acute phase reactants, for example, PCR or procalcitonin and so on, are not able to distinguish between viral and bacterial forms, in the sense that entering in the details, clinical details, few viral infections may present from a laboratory point of view as bacterial infections. I mean, influenza, pneumonia, or pneumonia due to adenoviruses, and so on. Such microorganisms determine a high phlogosis, high inflammation in the lung. So protein C reactive may be high as when we are in front of a bacterial pneumonia. So there is a great overlap between PCR values in bacterial and viral cups. And the answer to the question of Professor Pinburg is a bit difficult. I think that the knowledge all over medical doctors, pediatricians, not only in hospital but also in community, the knowledge of the kind of presentations of pediatric pneumonia probably is the best thing to understand the clinical picture of the child we are in front, and to decide if to decide that the antibiotic choice or also the wait and see management.
The next question is to Ameena. And do you think it's necessary to create local clinical guidelines for the management of pneumonia?
I think it's important because I think one has to assess what the local pathogens are and what the local sensitivities are so that one can provide appropriate guidelines. So I think it's good to be guided by international guidelines, but take them and adapt them for a local level to make them absolutely relevant. And that local level might not just be a national level. That local level might be for your hospital, for your unit, so that you make sure that you're giving the most appropriate kind of care to either prevent or to manage community-acquired pneumonia. So I think it's very important. Yeah.
Okay. And one more question, again to you, Ameena. What's the role of maternal immunization in primary prevention of pneumonia?
Yeah, that's a really interesting question. And I think it's still under investigation. So I know that there are two, well, I guess one can say three things. And one is under investigation at the moment, and I think the other in the future. So the one is there have been studies on maternal immunization with influenza to determine whether that reduces the risk of pneumonia or illness in children, in neonates. So that's the one example. And I know studies are already underway. The other two are around HIV and RSV. So RSV, I think, is still under investigation. So does the administration of an RSV vaccine to a mother reduce the risk of infant RSV infection in the first few months of life? So I think that's still under investigation. And the second one is HIV vaccines or HIV monoclonal antibodies. And so does the administration of that to mothers reduce the incidence of either community-acquired pneumonia, mild or severe, in their children? So I think there's a lot that we don't know about maternal immunization, and I think we need to learn about it because it's another way of protecting children as soon as they're born.
Yeah, and we are seeing some data coming out about COVID vaccination and the
Yes.
transfer of
Yes.
antibodies to neonates born to mothers who are vaccinated. So it's
Yes, exactly.
Yeah. Max, this question is to you. What diagnostic tests for atypical pneumonia organisms are done in high-income countries?
Well, in general, in not severe cases, also the guidelines does not provide the use of microbiological tests. In case these tests are necessary, we use the real-time PCR for atypical bacterial for the analysis of biological samples from the upper respiratory tract, and for study purposes, also the paired serology.
Okay, and Stefan, do you have any? Sorry, Stefan, do you have any question?
Maybe one more for Dr. Goga. Over and over again, barriers to access to health care, including poor symptom recognition, have been shown to lead to like detrimental outcomes in pneumonia in low and middle income settings. And you touched on it a little bit, but to your mind, what are the main barriers and how have they been addressed? How can we address them? Do you have any thoughts on that?
Yeah, I think if you have to take that to the first level, the first level would be care seeking. You know, and how do you make sure that families or mothers or parents know that this child is quite sick and needs to seek care, you know, so that they don't stay with them at home for too long. And so I think we started off in the 90s with lots of kind of promotional material about diarrhea and pneumonia. And then, you know, everybody was criticized because it was felt that those programs were too vertical and everything needed to be integrated. And so we went through, you know, the integrated management of childhood illness, which is still a good program, but I think we lost some of the messaging in between. And so I think the very first level would be to make sure that parents and families understand, when should I be worried? When should I take my child to seek care? Then at the health facility level, I really think it's important for healthcare providers. And here I'm taking a broad definition. I'm not just talking about the nurse who's going to see and treat the child. I'm talking about everybody from, you know, the security guard realizes that when a mother brings a baby for care, that mother is really worried about her child. So don't turn them away because they're late or the clinic is closed or about to close or the immunizations are finished or whatever it is. You know, allow them access so that they can be assessed. And then to make sure that anybody working, so that the nurses or the doctor working at the health facility is adequately trained to differentiate what is severe and what needs onward referral and what can I manage here. And oftentimes it's the basic things that we can put in place to make sure that at that very early level, we triage, well, firstly, there's no delayed care seeking, but secondly, we triage children appropriately so that those who need higher level care are sent on without delay, and those that can be managed at the health facility are managed without delay. I think, you know, when I looked at the literature again for this talk, I realized that there's not a lot of work that has been done on community-acquired pneumonia over the past, 10 years, you know, so we're dealing with old information and old data, but we're sitting with a problem that we've really not managed to solve since the early 2000s. And so we need some it's not just reinvigorated energy, but we need to see if anything has changed. And what systems can we put in place, or what interventions can we put in place to make sure that at that very lowest level, things work? Because if things don't work at that level, we start seeing more and more morbidity and mortality at higher levels of care. So I don't think I've got answers. I've got more questions, you know, because we've not
Questions are good. Questions are good.
Yeah. Thank you everybody for attending this talk. Thank you, Ameena. Thank you, Max. Any questions which are answered live during the session will answer. You will reply either by email. The two speakers will be provided your questions, and you can still have a look at the talk again on the ERS YouTube channels and on the PATS YouTube channel. From Kenya, I'd like to wish you good night and see you at the next webinar. Thank you, everybody.
Thank you very much. Bye.
Thank
See you.
you. Thanks so much, everybody. Bye.
Thank you very much. Bye-bye, everybody.
Bye.